as well. And so we were able to do the cadavers last night. We started about, I think we finished class at 8:30. And during some break time, I had moved them into the other room. So I need to check and see when that classroom is available, but it doesn't go as long as we do, so we should be able to do this evening. So we're going to finish up lower extremity tonight by looking at the muscles of the buttocks, and then we'll do the thigh, take a break, and what we did last night, that was study break, and the lab quiz was an extra credit 3-point question on the muscles that we've covered until that time, okay? From starting with the buttocks through the thighs. And then we'll come back. I think students took about an hour of study time before we did the quiz. And then we came back and did the legs, and it took about 45 to 50 minutes. And then went to the cadavers, okay? So, again, next week is vacation. Jeff is doing open lab tomorrow, and again, during spring break on Wednesday, from 11 in the morning to 7 in the evening, okay? Because Friday is, campus is closed, okay? All right, so looking at the muscles of the, in fact, go ahead and get muscles, the model. I'll wait while you get them, the ones in the back on the lower limbs. 11 to 7 on Wednesday, 11 a.m. to 7 p.m. on Wednesday, which is the 17th, I believe, but yeah. And that doesn't count towards the total. You can use it for your hours, but it doesn't count towards the number that have to be.
Okay. Oh yeah. No, that's purely for helping study. That's more beneficial for that.
Pass it over here by 7:30.
Yeah, I'm not gonna go and get here in like
Sorry, Carol.
All right, so the buttocks area is homologous or similar in structure and function to our shoulder. And these muscles will be doing the abduction lateral rotation that our rotator cuff muscles are involved in. But we switch it. Remember, we had most of our muscles in the shoulder were involved in medial rotation. We have 4 muscles we describe for medial rotation and 2 muscles that we describe for lateral rotation of the humerus. And so we switch that around when we get to the lower extremity. And we have 2 muscles for medial rotation and at least 4 muscles for lateral rotation, all right? So the large muscle that most of you are familiar with for the buttocks is the gluteus maximus. And while that is homologous to the deltoid, it does not have the same major characteristic function. Remember the deltoid muscle inserted laterally onto the deltoid tuberosity, and the gluteus maximus inserts posteriorly onto the gluteal tuberosity. So if you recognize where that point of attachment is, deltoid's major function was abduction, pulling on the lateral attachment, and gluteus maximus' major function is extension, okay, because its attachment is posterior. So when we look at the lower limb and we review the movements, let's remember first what the humerus at the shoulder is, all right? So moving the humerus forward like this from a straight down position of 180 degrees, where you bring it up to 90 or bring it up to 0, that is decreasing the angle, and we're looking at flexion, okay? Bringing it back down again, or back beyond 180 degrees is extension. Taking the humerus away from the midline is abduction, and bringing the humerus back to midline is adduction, okay? Then if we take the humerus and circumscribe a circle, circumduction at the hip joint. All right, so when we look, at the shoulder joint, so if we look at the lower limb, the same relationship of anterior to posterior, lateral to medial occur, although it does not at the knee to the elbow. So flexion of the hip is this way, decreasing the angle, all right, and then increasing the angle is extension, or continuing to bring it back is extension, all right? So bringing it forward at the hip joint, bringing it back, flexion, extension. We looked at that a little bit when we were talking about the ligaments at the hip, okay? Then moving the thigh away from the midline is abduction, and bringing it back is abduction. Okay? We have rotation as well at the hip joint for the femur, but it looks different, all right, because of the fact that the knee, when we flex the knee, is a posterior flexion, a posterior movement, and then extension is still straightening it out. But the knee joint and the leg are rotated around compared to the forearm. So because of that, when I take my femur and I rotate it internally, notice what happened to my humerus when I rotated my humerus medially or internally, it came across my body. However, because I flex my knee the opposite direction, when I rotate my femur internally, my foot goes away from my body, okay? So this is medial rotation. If you do it, you can feel your whole femur do internal rotation. And so if I start out like this and then do lateral rotation or do lateral rotation across my foot over my knee, then the foot's going to come across my body, which is the reverse of the way the hand moves in relationship to the humerus. My femur is still moving the same direction. It's just what the foot does, whether it crosses the body or moves away from the body, okay? So and it's always a good idea when you're reviewing these muscles to do those movements, all right, so you can actually feel the change in the position. So gluteus maximus is primarily femur extension, although it can, depending on the position, do lateral rotation. All right, most of our muscles that do rotation are going to do lateral rotation. So if you take that muscle off of your lower extremity model, if it's not off already, then we see these deeper muscles of the buttocks. Look at the orientation of the fibers. For gluteus maximus, that's why it can do lateral rotation a bit. Whereas gluteus medius, let's come back here. Gluteus medius, its fibers, it's a more anterior muscle. So it's oriented more towards it. Anterior aspects of the hip joint, rather than going this direction, it's up here. And its fibers are more straight up and down. So this is an abductor, okay? This is going to be homologous to the supraspinatus muscle. Although the supraspinatus was only the initiation of abduction, it wasn't a major abductor, gluteus medius, and we're not learning the muscle deep to it because it does the same thing and we can't see it on our models. If we were to take off the gluteus medius, gluteus minimus is like a tiny little twin, just a couple of inches shorter, and both of those are abductors, okay? Now, do you remember the common bony attachment for the first three of our rotator cuff muscles, the SIT? What was your common attachment bony process on the humerus? Close, but tubercle.
Tubercle.
Yeah, I know, we're in the lower limb here. So these deeper muscles all have the common insertion of the greater trochanter, all right? So gluteus medius, which is an abductor, and a medial rotator. All right, so it's one of our two medial rotators. Inserts onto the greater trochanter. So it's not doing the going, which is pulling that, what's the word I want, band out, that's abduction, and then abduction is bringing it back in, okay? So that's gluteus medius. Deep to it would be gluteus minimus, and as we move in downward, this is piriformis. So piriformis is the one here with the asterisk. And on your models, you can find it easily if you look for the sciatic nerve. Because most of the time, the sciatic nerve, both of these will pass out of the greater sciatic notch or through the greater sciatic notch, the sciatic nerve and the piriformis muscle. And so sciatic nerve in our models comes out just inferior to the lower edge of the piriformis. In real life, it can be variable. That's the most common. It can come out between, so through the muscle itself, or it can come out superior. There's often complications if it comes out through the muscle itself because an inflamed piriformis can result in sciatic pain, okay? Pain down the posterior aspect of the leg. So this also attaches to the greater trochanter, and it's homologous to our infraspinatus. So it's going to do lateral rotation, like you're crossing your foot over your knee. Right? External hip same as lateral. Supraspinatus. Actually, it's homologous to supraspinatus, but in the hip, it's the major abductor. And supraspinatus was a synergistic abductor. All right, now, there's a lot of muscles here, and let me just turn a little bit more contrast. And they all do lateral rotation. So we have two twin muscles, superior gemelli and inferior gemellus and quadratus femoris that we're not doing, all right? So to find the one that we are doing, find the piriformis, skip one of these skinny ones, and we're taking the next one in between these two skinny ones. And that is the obturator internus. So this is a much more dramatic muscle than it appears to be on the buttocks because there are actually two, an obturator internus and externus. The obturator internus comes off of a piece of connective tissue, fascia, covering the obturator foramen. Remember I said only three little things pass through it, an obturator artery, nerve, and vein. And the rest of it is covered with a band of connective tissue. And that forms the origin of the obturator internus. And then it passes through the lesser sciatic notch and becomes very narrow as it tapers to attach to the greater trochanter. Okay. Again, lateral rotation. So this would be like the teres minor, okay, as far as function here. So you don't need to know the nerves for any of these muscles that are in the buttocks or in the lower pelvis, crossing anteriorly. I have a favorite story I tell about the obturator internus though. And when I was taking the cadaver gross anatomy course with medical students for my doctoral program, our lab exams were always on cadavers. And they were multi-level, it wasn't like name this muscle or name this nerve. They could be multi-level. And there we had 2.5 minutes per station. And then we moved to the opposite side of the cadaver. And they were multiple choice. So as I tried to get you to do, I would always try to come up with the answer before I looked at what was available. And so the obturator internus was pinned, but the question was identify the nerve to this muscle. So first of all, you had to, in your mind, identify the muscle and then come up with its innervation. And so I was determined to identify the nerve before I looked at the answer choices. And I spent 2 minutes of my 2.5 minutes racking my brain trying to figure out, going through all the nerves that I knew were in the area. The superior gluteal and inferior gluteal and pudendal and about 3 other nerves there. And I knew that none of them were the right answer. And I could not think of a single other nerve in that area. So I finally, with 30 seconds to go, looked at the list and I almost laughed out loud. So I recognized the answer instantly. And the nerve that innervates that muscle is called nerve to the obturator internus. I recognize it because I'd been studying it, I just couldn't think of that one I was trying to, so of course that's the one I've never forgotten. So, the ones that we're learning from the posterior view are gluteus maximus, and then deep to gluteus maximus, gluteus medius, and piriformis, and skip one, and obturator internus. Okay? So gluteus maximus is extension, gluteus medius is abduction, piriformis and obturator internus are 2 of our muscles that are going to do lateral rotation. All right, so let's go to this muscle here that was out of sync. And this is our second medial rotator. All right? It's slightly anterior, but it's more lateral than gluteus medius is. It does abduction and medial rotation. Okay? So it can do abduction, but that depends on the position, so we're just going to leave it at abduction. And if you look at your model, you'll find gluteus maximus, and then there'll be this band of white matter, which most people nowadays call the IT band, or the iliotibial. It's also called the fascia latae. And so the muscle is the tensor fascia latae. All right, it doesn't really directly attach to bone. It blends into that IT band. So I call it the coffee muscle, latae. So it's very short and cute right here. And if you're lying on your side and doing a lot of thigh lifts, leg lifts, you're going to feel that start to burn right there, okay? And so it's going to do abduction and medial rotation, just like gluteus medius. Those are our 2 medial rotators, okay? We had 2 lateral rotators for the upper limb and 4 medial rotators. When we flip that around, we have 2 medial rotators and 4 lateral rotators. So the 4 lateral rotators are obturator internus and piriformis. And now we're going to see the other 2 as we move around to the anterior aspect of the body. And these come off of the posterior wall, anterior or superficial to quadratus lumborum. Remember that muscle that was the pterodactyl spiny? And we can only see it if we look at the posterior abdominal wall with the organs gone. So here is our quadratus lumborum, okay? Right there and there. And then these 2 muscles are superficial, so the long one is psoas major. And then coming off of the iliac fossa is iliacus. Those 2 muscles come together and pass under the ilioinguinal ligament to insert onto the lesser trochanter. And they also do lateral rotation, all right? They're going to flex the knee. Flex the thigh. They're very strong hip flexors, but they cross the hip joint, as you can see in the image up here. They cross the hip joint and wrap around from medial to lateral to grab onto the lesser trochanter. So they're the only 2 muscles we have on the lesser trochanter. And as you can see by the orientation of those fibers, because they come from the medial aspect and grab onto that, when they pull, they're going to take the bone and rotate it laterally. Okay? So they're going to grab onto the lesser trochanter, and then as they pull, they're going to do lateral rotation. So I think your lecture notes, I know my PowerPoint said medial by mistake. Check your lecture notes because it should be lateral rotation. Okay. So here on the small torso, psoas is iliacus and psoas major. So iliacus again stands for its origin. And then when we look at psoas major, you can see on the same slide, they have that common insertion onto the lesser trochanter. So you'll see the small image here of the woman doing sit-ups, and she has her hips flexed. So you're not supposed to do sit-ups with your knees extended. You should have your knees flexed. You may not have to flex your hips, but you should have your knees flexed so that when you do sit up, you're using your abdominal muscles to pull up the torso, because the iliacus and psoas major are so strong that you're stronger than your abdominal muscles, and you'll be using that muscle, especially psoas major, to pull your torso up. So by flexing your knee, bringing your knee up, you're shortening the distance. So even if that muscle contracts, it's not going to be able to create tension. Okay? So that forces you to use your rectus abdominis and oblique muscles to be able to pull up the torso. All right, so 4 muscles that do lateral rotation are piriformis, obturator internus, and psoas major and iliacus. So we don't call them iliopsoas until they have passed under this inguinal ligament. Okay? And we see just a small triangle of them in the anterior head. All right, so now we're going to start looking at nerves again. We're moving into the compartments. So when we looked at upper limb, we had 2 compartments for the arm and 2 compartments for the forearm, right? We have 3 compartments for the thigh and 3 compartments for the leg. But I actually think the lower limb is easier. Certainly the leg is than the forearm, because we just have a lot of strap-like muscles in the forearm, and it's easy to get them mixed up. All right, so this is not one of our Scantron questions until we change files. It was left over from Tuesday because we didn't get to the buttocks muscles. So which of these muscles is going to function in lateral rotation of the femur? Just a quick short-term memory review. Iliacus and psoas? Yeah. Tensor fasciae latae? Nope. That's medial. Piriformis? Yes. And obturator internus. Okay. All right, so let me switch files here to get to the. All right, so get your Scantrons out. We'll do quiz number 19. Until it crosses under the inguinal ligament, which is a band of connective tissue. So right here. Yeah. And that right there is above it, we have separate.
It's weird. The femur. Where's the femur doing? Not the legs. Take a look. You can do it to yourself. I feel like
So,
you're rotating it internally.
if her foot starts here in the midline and it moves laterally, which way is her femur moving? Medially. Remember I said it was flipped? So if you actually do it yourself, while you're looking at that picture, it'll be immediately clear what you're doing. So to move the foot out, you have to turn your thigh inward or medially, okay? Now there is a little bit of rotation at the knee. If you go into kinesiology, you'll talk about it. You've probably heard that you're not supposed to lock your knees when you stand for a long period of time. So to lock and to unlock the knee requires rotation of the tibia on the femur or the femur on the tibia, and that allows it to be unlocked. If you're not aware of that, what happens when you lock your knees is there's a compression of the vessels that are immediately posterior. You can see them on your models. There's a popliteal fossa behind the knee because of the arrangement of thigh and leg muscles, and that compression prevents or slows down the flow, the return of blood to your torso, and that can cause fainting as blood pressure drops. Okay, so that's the reasoning behind that. All right, so this is medial rotation of the thigh. It's not a movement of the foot, although the foot moves when we rotate the femur. So which of these muscles is going to do medial rotation? Kind of the flip side of the praxis question we had.
About the no locking knees and marching band when I was and we got there. Everyone right before they were
Well,
like,
you
"Don't
see it
lock
at
your
weddings.
knees." Yeah, they're all the groom.
All right, so we have two sets of nerve plexuses that supply muscles of the lower extremity. We have the femoral nerve, which is an obturator nerve, which comes from our lumbar plexus. So, lumbar plexus is above. See if I could bring that nerve model plaque up here, spinal cord that we looked at a while ago.
So you said it was the femoral nerve, the lumbar?
So this is a view of the posterior abdominal wall. It's actually a good illustration of our quadratus lumborum and psoas major and iliacus muscles. So here's quadratus lumborum, and here's here's psoas major and iliacus. All right. So this group of muscles here, nerves here, we can see because psoas major has been removed, and this is the lumbar plexus. And this nerve coming down here is the femoral nerve. All right, so it's partially covered up by the psoas major over here. It's gonna go over the pubic bone and into the anterior compartment of the thigh. And then obturator nerve is going to come down here and pass out the obturator foramen, that's right there, and goes into the medial thigh, all right? So from lumbar plexus, you don't need to know spinal cord numbers, but we have femoral nerve. And this is going to be supplying anterior thigh, both motor and sensory. And I haven't really emphasized sensory because it's found with the same motor components, except musculocutaneous. If you recall, I said the sensory for the cutaneous part was the lateral forearm, and then when it got to the anterior arm, it was both motor and sensory. That's the cutaneous portion. Well, the femoral nerve is homologous to our musculocutaneous nerve, all right? So when we look at its sensory supply, the light blue here is along the big toe. Remember, the foot is rotated over compared to the hand. So the big toe is homologous to our thumb. So musculocutaneous is sensory from that lateral region along the thumb. And femoral nerve component, we're going to call this a different name, is sensory from the thumb equivalent, the big toe side of our leg, which is medial leg. So that particular nerve we actually give a different name to, all right? So saphenous nerve is sensory from medial thigh. And then we call them femoral nerve. This is going to be motor and sensory from anterior thigh. So very similar in pattern to the musculocutaneous nerve. We just call the cutaneous part of it a different name, okay? The saphenous nerve. And then we have the obturator nerve. And that's doing the medial thigh. The rest of the lower limb, posterior thigh, and all of the leg are done by components of the sacral plexus. And we'll review that when we get to the posterior thigh, okay? But our tibial nerve and fibular nerves and so on are coming from the sacral plexus. So anterior and medial thigh are done by lumbar plexus. You can see obturator nerve here barely coming through the obturator foramen. When we get to bio 431, we'll see saphenous again because it's the name of two superficial veins that are just below the skin. The great saphenous starts in the medial foot, comes all the way up the thigh. It's the longest vein in the body and often used for coronary bypasses. So you'll see some individuals that will have 18-inch long incision in their medial leg where that vein has been harvested. All right, so muscles of the anterior thigh are going to cross the hip, and some of them will cross the knee. All right, some of them will only cross the knee. So, and apparently it says in your lecture notes not to learn about the vastus muscles. I have no idea why, but we are, and they're pretty easy, okay? You've probably heard of the quads. So our quadriceps femoris muscles are formed of the three vastus muscles, which means large, and the rectus femoris muscle. So I usually describe the vastus muscles as a hot dog bun, and the rectus femoris muscle, which fits in the middle, as the hot dog itself. Okay? None of the vastus muscles cross the hip joint. They only cross the knee joint. So they're the equivalent, essentially, of our brachioradialis, which does not cross the shoulder joint. But the brachioradialis flexed the elbow. So our thigh is in the same relationship as our arm. It's the leg and foot that are rotated around, okay? So when the tendons of the biceps, of the rectus femoris and the vastus muscles insert onto tibialis posterior, tibialis, the tibia bone, instead of flexing the knee, they're going to extend, okay? So that is the role of the quadriceps femoris muscle. Or muscles. We'll put a couple of ends here, all right? So the three vastus muscles, vastus medialis. In order to see the vastus intermedius, you have to take the rectus femoris off. So if you have your models at the table, most of what we see of vastus intermedius is just this connective tissue sheath. All right, a little bit of it up here, but most of it is just this connective tissue sheath, and you don't see much of the muscle fiber. So vastus intermedius, and that's going to lie immediately deep to the rectus femoris. And then laterally, vastus lateralis. Vastus intermedius lies immediately deep to the rectus femoris. Okay? So these only cross the knee. Then our rectus femoris is going to cross both joints, similar to how the biceps brachii crosses both joints in the arm. All right? So rectus femoris crosses the hip joint, and it's crossing it anteriorly. All right, so because it's in front of the hip joint, it's going to do flexion of the hip. And then, because it crosses the knee joint, it's going to do extension of the knee.
If it says flexus hip or flexus thigh, does that mean flexus hip? Is it like the elbow
Yeah.
and the forearm? Okay.
So thigh is femur,
Okay.
so it's flexing
Okay.
the femur, okay? So it's going to join the vastus muscles and attaching to the tibial, the muscle there, tibial tuberosity. So remember the nerve is the femoral nerve. And these are the only muscles to extend the knee. So if we lose the femoral nerve, we lose the inability to extend the knee. Just like if we lose the radial nerve, we can't extend the arm. Okay, there's no other muscle in any other compartment that extends the arm. So all three compartments of the thigh have at least one muscle that flexes the knee, but only the anterior compartment extends the knee. Rectus femoris comes from the anterior inferior iliac spine. So it's covered up, if you look at your models, it's covered up by the tensor fasciae latae, which comes from the anterior superior iliac spine. And the next muscle we're going to talk about, which is sartorius. Okay? So, looking at your model, right up here, here's psoas major and iliacus. This is iliopsoas right here, where the two of them come together to cross under the inguinal ligament. And here's rectus femoris. So you can see how tensor fasciae latae covers over rectus femoris because it's coming off of the anterior superior iliac spine. And then our next muscle, the last one in the anterior compartment of the thigh, is the sartorius. Okay. It starts laterally from the anterior superior iliac spine, crosses medially to cross the knee joint. So like our rectus femoris, it crosses both hip and knee joints. Okay? So the word sartorial means close or tailor. to the woman sitting cross-legged. This does 3 movements that you need to sit cross-legged. So it's going to flex the thigh because it crosses the hip joint anteriorly, all right? It's going to flex the knee because it crosses the knee joint, but medially, not anteriorly. So it's not going to extend the knee, it's going to flex the knee. So this is the one muscle of the anterior thigh that flexes the knee. And then, because it starts lateral and goes medial to grab on to the tibia, it's going to do lateral rotation, okay? So you need all 3 movements to sit cross-legged. Flexion, lateral rotation, flexion of the hip, lateral rotation of the femur, and flexion of the knee. And so sartorial, someone who has a lot of clothes, spends a lot of has a lot of sartorial expenses. Because before sewing machines were invented, usually men would sit outside their places of business, cross-legged, and sewing garments. All right, so that's where that term comes from. So it inserts onto the medial bone of the leg by crossing out as it crosses the knee. We have 3 muscles that come together at that point, all right, called the goose's foot, because the 3 tendons have the appearance of the webbed appearance of a goose's foot. So those are our 5 muscles of the anterior thigh. The 3 vastus muscles, we can't see vastus intermedius here because rectus femoris is covering it, and the rectus femoris and the sartorius. Okay. So in this bodybuilder image, and you can see it on your models as well, here is that V created by the 2 muscles that have their origin from the anterior superior iliac spine. Tensor fasciae latae and sartorius. Okay. And here's rectus femoris. Here's the huge vastus medialis and vastus lateralis. They kind of overwhelm the rectus femoris. Okay, so now we're leaving that anterior compartment of the thigh. 2 major movements would be flexion of the hip, extension of the knee. Okay, but the one muscle of that compartment that flexes the knee would be the sartorius. All right, now we're moving to the medial thigh. What do you think the major function of medial thigh is? All of its muscles have their origin from the pubic bone. Superior pubic ramus or inferior pubic ramus or ischial ramus, so all that medial aspect. So it's going to bring it towards the midline of the body. Adduction. In fact, almost all of them have the name adductor in front of them. Okay? Because I cut out some muscles, we're only doing one adductor, the largest one, adductor magnus, and we're doing gracilis. Okay? So adduction is where she's starting out laterally and then bringing the foot forward. She's not just bringing it to midline, she's bringing it across the midline, but that's still adduction, okay? So adduction that we saw with tensor fasciae latae and gluteus medius is doing this, and then bringing it back or even across is adduction. Okay, my balance is much better today. Yesterday I was having to hold on to stuff while I was doing all that movement. All right. So remember we said that the femur was angled medially. It started out wide at the hips and came inward. So it's that triangular gap that's filled in with our adductor muscles. And we're not doing longus and brevis, but we're starting out with magnus here, and it does not cross the hip joint. It does not cross the knee joint. It comes to the medial epicondyle. There's a little bit of a bump there that I didn't have you learn, the adductor tubercle, but that's where it attaches. So it's going to pull in. Now, it's a massive muscle. And posteriorly, it inserts onto the linea aspera. Remember that process? We have the gluteal tuberosity, triangular, and then it narrowed to a parallel set of rough lines, and that's the linea aspera. And it came down until it widened to go to the epicondyles. So because it comes in so far posteriorly and so far down, it is going to be an extensor. It's going to be synergistic to gluteus maximus. It's also listed with muscles that flex the hip, but you can cross that out because that's a minor function, okay? So we're gonna be interested in adductor magnus as adducting, that's its primary function, that's what it's an agonist for, but it also is a strong extensor. In fact, if you, I wanna borrow your guys', lower them. So, a brand new one. So if we look in the back, this would be, well, let's start out first on where we normally find it. So this is medial compartment of the thigh, okay? Pubic symphysis has been cut in a sagittal section. And find this wide muscle that runs straight up and down the medial aspect of the thigh. That's the gracilis. That's the only one that crosses the knee joint. And then if you look both anterior to it, low down, and posterior to it, high up, that's adductor magnus. It looks like it has several folds and it's several different muscles, but all of this up here is adductor magnus. Okay? And you can see a little bit right down here between the gracilis and the vastus medialis. Where you can see even more is if we take off the hamstring muscles in the back. So now we're looking at the posterior surface of the lower extremity. Here's the muscle I just told you was the adductor magnus, all right? And all of this is as well. So it's like a triangular muscle, and the fat part of the triangular faces posteriorly. And so that's why it's considered to be such a big muscle. It has the name adductor because so much of that is seen, and that's where the fibers are that are going to be doing extension as well. Okay? So we usually don't see that unless you take off the posterior thigh muscles. So adductor magnus does not cross the hip joint, but it will extend the thigh and it will adduct the thigh. Now, that muscle that went straight up and down, crosses the knee, and passes medially as well. The gracilis is the one muscle of the medial thigh that functions to flex the knee. Remember I said there was at least one muscle in each compartment? So, sartorius was the muscle in the anterior thigh, and gracilis is the muscle in the medial thigh. So let's take a look at that one. So these are the models that are in 418. Here is sartorius, here is gracilis, and here would be adductor magnus, and down here between gracilis and vastus medialis would be adductor magnus as well, okay? So now if we look at gracilis, gracilis is the one shown here in green. This would be adductor magnus here, right? And it crosses the knee medially, so it's going to flex the knee. It has to cross anterior to do extension. So it can do adduction of the femur and flexion of the knee, okay, which is pulling the foot up behind you. Part of gracilis, I found this when I was redoing my lectures for this semester. Someone is lacking innervation to the zygomaticus or has damage to the facial nerve. One of the treatments for it is to take a piece of the gracilis muscle and transplant it to the face to replace the zygomaticus. I saw another illustration that was a little more difficult to follow, in which they did not remove a piece. They cut the gracilis from its attachment, brought it up through under the inguinal ligament into the perineal area, and used it to make an external anal sphincter. So the innervation, the blood supply was all kept intact. It took some training to consciously think of using that muscle, all right? But surgically it was probably easier than trying to attach nerves and blood supply and keep that tissue alive. All right, so now we're ready to move to muscles of the posterior thigh. So we're now switching innervation from the lumbar plexus to the sacral plexus. All right, so let's talk about that just a bit. And we see a homology between the innervation of posterior arm and posterior forearm to the innervation of posterior thigh and posterior leg. Remember, we had radial nerve doing all of posterior arm and radial nerve doing all of posterior forearm. So in a similar fashion, we have the tibial, it even has the same last three letters. We have the tibial nerve doing posterior thigh and tibial nerve doing posterior leg. Okay? So, coming out of the greater sciatic notch, inferior to piriformis, you can see the sciatic nerve on your models. So I'm diagramming a right lower extremity here. There would be the greater sciatic notch. And coming out of it would be the sciatic nerve. Remember we talked about how the pudendal nerve comes out as well and then passes over the ischial spine to pass back into the perineal area to innervate the muscles of the pelvic floor, the levator ani, bulbospongiosis, ischial cavernosus, where the sciatic nerve is actually made up of two nerves. The sciatic nerve doesn't innervate any muscles by name. Okay, we don't have any muscle that says sciatic nerve innervates. Sciatic nerve is just our name for the combined tibial nerve and common fibular. So the more lateral nerve is the common fibula. Remember the fibula is our lateral bone? So common fibular is going to come out of the side, out of the greater sciatic notch. And just above the knee, about 3 to 8 inches, it's variable, it is going to move laterally where it wraps around the fibula. So this is the this is the common fibular nerve. Old name is peroneal, okay? And then part of it will stay laterally to innervate our lateral compartment, and part of it will move anteriorly and deep to innervate our anterior leg compartment. So I'll label those when we get to the leg after our study break, okay? In the meantime, the medial nerve, medial component of the sciatic nerve is our tibial nerve. And it stays medial and stays posterior and goes all the way down posterior leg and actually onto the bottom of the foot. So muscles that are on the bottom of our foot are innervated by branches of tibial nerve as well. Okay? So this is tibial nerve and this is tibial nerve. So it's going to do posterior thigh and posterior leg. So we have 3 muscles in the posterior thigh, one of which has 2 heads, okay? And those are all innervated by the medial component of the sciatic nerve within the posterior thigh, although the short head of our biceps femoris is innervated by common fibular. Just to be accurate. All right, so these muscles that form the posterior thigh compartment are commonly called the hamstrings. Because if you feel behind your knee, you can feel 2 thick cords of tendons, and these come from the 3 muscles of the posterior thigh. One muscle is lateral and attaches to the top of the head of the fibula. Two muscles are medial and attached to the medial surface of the tibia near where our sartorius and gracilis attach. And they have a common origin, which is the ischial tuberosity. Okay. Remember how that was really rough and large because these muscles are pulling on it. So here's biceps femoris coming off of the ischial tuberosity and going lateral to attach to the very top part of the fibula. And this is an exercise I hate. I can't stand to do it, but I found last night I don't mind if I do it standing up. It's hanging the head and pulling my knee up to my chin that I don't like. All right, so this is what the hamstring muscles do. The long head at least. So extending the thigh and flexing the knee. All right? So what I hate is doing this. That one feels good to stretch out. Okay? So extension of the thigh and flexion of the knee. So if you're on a machine at the gym and that roller goes across the back of your ankles and you're working on that, you're doing a little bit with the gastrocnemius, but you're mostly using your hamstrings. Okay? So the long head of biceps femoris crosses both joints. Whereas the short head, obviously it's too short. And now that wasn't true for biceps brachii, so I shouldn't say obviously. Because short head was also crossing both joints. So biceps femoris, long head, crosses two joints. Crosses the hip, where it does flexion of the hip, extension of the hip. Extension of the femur. And it crosses the knee, where it's going to do flexion of the knee. Okay? Short head only crosses the knee.
Do you want us to know the short head?
Yeah. But the other two muscles are pretty big, so you don't miss the force of missing the biceps femoris crossing the hip joint for extension. Plus we have our gluteus maximus that's going to be doing extension as well. Okay. So if we lose the tibial nerve, we're still going to be able to cross the knee. If we lose the tibial nerve, we're still going to be able to flex the knee. Cross the hip, extend the hip. We're still going to be able to flex the knee because we have other muscles that do that with other nerves. Okay. So how do you remember that this is found on the lateral? That it's our lateral group of muscles from those two long columns of muscles. What's the letter of the lateral bone of the leg? An F for fibula. All right. So if you remember that the F in biceps femoris can also stand for fibula, it's on the fibular side of the thigh. Okay. So now we have the, I suppose you could call them twin muscles. They're on the opposite aspect. They go medial. And both of these muscles cross the hip and the knee. So if I can erase biceps femoris. These two muscles are called the semimembranosus and semitendinosus. So the wide muscle coming off the ischial tuberosity and coming down to attach to the medial aspect of the tibia. The deeper muscle, and I'm exaggerating, it's not quite that wide, is semimembranosus, all right? So it crosses both hip and knee, extends and flexes, all right? So it's going to extend here and flex here. And how do you remember that this is medial? M for medial. Okay. Then the more narrow muscle is superficial, but it has the same origin and the same function. And that's tendinosus. So how can you remember that that one is medial? T for tibia. Okay. So those are the three muscles, biceps femoris long and short on the lateral aspect, and semitendinosus, and semimembranosus, superficial and deep on the medial aspect. Okay. All right. We're going to stop here and take a lab break. All right. And we'll have 3 questions of extra credit lab quiz. I'll pass out the green sheet. And on the muscles that we started with gluteus maximus. Okay.
On the model that we just talked about.
Sure, yeah. So remember, when you're studying the muscles as well as looking at them for quizzes or exams, you always want to take just a few seconds is all it takes is to figure out where you are. Are you in the upper limb or are you in the lower limb if you are one of those? What compartment are you in? Is it anterior or posterior? Are you on the big toe side or the little toe side? Because that's going to make a difference. Are you anterior, on what muscles you have available to choose from. So on the posterior compartment, here's the big toe, so this would be medial. Here's the little toe, so this would be lateral. All right? And this is the common attachment of the ischial tuberosity. So lateral is going to be my biceps femoris, and this long one is biceps femoris long head. And biceps femoris short head is down here near the knee. Okay? Kind of like our medial head for triceps brachii. All right, and then these two that don't come apart. So the more superficial muscle is narrow, and we can see why semimembranosus deep to it. And so semitendinosus, and the wider, deeper one is semimembranosus. All right. When you look at where they come together down here on the tibia, that's the pes anserinus. And so that's made up by the attachment of sartorius, which is missing there, gracilis, and semitendinosus. Semimembranosus actually stops a little short, so it's not officially included. Okay? So I'll show that to you just before I have those slides next. But again, if you pay attention to, before I do that, let me show you the nerves here. So here's sciatic nerve, passing inferior to piriformis, and the two of them tibial and common fibular traveling together. Tibial continuing down the posterior leg, and common fibular traveling laterally. Okay? Cutting across the fibula here. We won't be able to see superficial in its compartment, but we can see superficial here on the anterior leg compartment, and deep fibular is deep too. So we'll cover those when we get back. Well, let me show you the pes anserinus. And then we'll break for study time. So here's the medial, here's sartorius. This is the muscle from next door. Here's gracilis. Here is semitendinosus. And those come together on the medial side of your lower knee, on the side of the tibia. And between those tendons and the connective tissue on the bone is a sac of fluid for lubrication. It kind of rolls back and forth. Think of a balloon with a little bit of lubricant fluid in it. So as you move your knee and leg, that provides lubrication over that area. This summer, I showed you the picture of me running for after I finished that half marathon. I didn't run a lot of it. Part of the reason I wasn't running was I started training first week of July. And my husband and I had a program so that we would have run 10 miles at least by the 1st of November. The run was November 7th, I believe. And so The first couple of days, we just did probably not even a mile, 3/4 of a mile, run a block, walk a block. I mean, walk a block, run a block, whatever. And the next day, we did 2 blocks and took a break, and then the third day, repeated it. Well, that weekend was a really hot weekend that we went up to the mountains. And it's at 11,000 feet. So we weren't acclimated to that. We walked uphill to the ski gondolas and then ran and walked about 3/4 of a mile back to the house. The next day, we ran a little bit uphill and ran and walked back. And came back, and on Monday, I was ready to go. Steve slept in. So I got up and I did 3 miles. I only ran and walked 2, but it felt really good. Tuesday, I cut back. Wednesday was a break. Thursday, I went out, and my knees were sore. Both of my knees. So I walked. Friday, they hurt even more. So I looked it up, diagnosed myself, and it said, don't do any exercise. Don't even walk. Which was fine because I couldn't even go up and down the stairs without using the handrail. And that lasted for almost 2 months. We had gone up to visit my sister, and her daughter's a physical therapist, so we stopped by her house, and she said to ice it, but not the typical, you think of putting ice on it. She said to put ice, and I just put it in a muslin bag, like you might jelly or something with, and I rubbed it like every hour for 5 minutes, and I was fine the next day. Could go up and down the stairs without any problem. I continued to ice it like that for another week or so. But then I came back to school and convinced myself I didn't have any time to train. So that's why I went off and did the half marathon without training. Which was surprised I didn't get the pes anserinus back, but I didn't. All right, so that's medial aspect of the thigh where these 3 flexors come in together. Okay. All right, so we'll stop there for now. As I said last night, it took about an hour. You can take whatever you want, more or less. And then when we come back, we'll have 3 questions from the buttocks and psoas major and iliacus from the front, anterior, medial, and posterior thigh. Okay? 3 extra credit questions in lieu of our Lab Quiz 12. Okay? I'm going to go next door and get the hours ready.